Now we will talk about cardioversion. As you recall, cardioversion is an intervention that's very different from defibrillation because it is not meant to address a life-threatening lethal rhythm such as a ventricular fibrillation or pulseless ventricular tachycardia. Cardioversion is meant to reverse a rhythm that makes your patient present with signs of shock and hemodynamic instability, and that cannot wait for pharmacological treatment. For example, this patient, if we look at the monitor, seems to be in a tachycardia that appears to be supraventricular, but it is really hard to tell because the heart rate is so high. What we also notice is that his blood pressure is extremely low, 61/40, so I know that my mean arterial pressure is quite low and probably not sufficient to perfuse the patient's brain. And I have also assessed the patient and noted that the patient's neurological status is drastically decreased and the patient is practically unresponsive. So this is a good indication for an emergent cardioversion. Now, cardioversion is usually done as an emergency procedure, but there does exist cardioversion that is elective. For example, for conditions such as new atrial flutter or atrial fibrillation, or an atrial fibrillation that is not changed with pharmacological interventions. So these procedures can be done electively, but in a critical care setting, you will see that cardioversion is also done as an emergency intervention. So my pads are already applied to the patient. You will also see that my 12-lead EKG is connected. And before I cardiovert the patient, I will make sure that my EKG is continuously recording at 12. My EKG machine is continuously recording a 12-lead EKG so we can later analyze our intervention. So what I need to do next is I will look at my defibrillator, and the procedure for cardioversion is a little bit different from defibrillation. What I need to make sure is that my defibrillator can actually read the patient's EKG. So what I need to do is I need to connect extra leads to my patient, and these come with the defibrillator. It's usually a 3-lead EKG that comes with it, and you will see that this plugs directly into the same connector as you have for the paddles. So my pads are connected here, and my EKG will go and connect right over here. Okay, I've got my leads connected, and I will place them on my patient, and I will tell you why I need my defibrillator to see patient's EKG. So white goes to the right. Oh, yeah, this is the right. Okay. And then we have black, smoke over fire. And I will make sure that this is all nice and tight. So now the patient's chest looks really busy. What we're going to do next is we're going to turn on our defibrillator and we'll look at how cardioversion is done. At first, I will put it to defibrillation again and wait for the patient for it to turn on. Now, what I'm going to do is I'm going to have to turn on the sync mode, okay? So let's talk about the sync mode. Why do you want, sync means synchronized, and the full name for cardioversion is actually synchronized cardioversion. What are we synchronizing to? We are synchronizing to the patient's heart rhythm, and there's a particular part in the QRS where you need to deliver a shock. Because if you think about your patient's electrocardiogram, you will remember that right after the QRS complex, you have a period that falls between the R wave and the T wave, where the heart is an absolute refractory period, and the second part of the T wave is actually quite dangerous because it's a partial refractory period, and the shock delivered there can actually precipitate a very lethal cardiac rhythm, for example, a ventricular fibrillation, which is the most common. So when we are cardioverting a patient, we need to make sure that our shock is not delivered near the T wave. So when we're cardioverting, we need to be able to monitor the patient's EKG, and the defibrillator needs to be able to deliver a shock just after the R wave. So the defibrillator is connected to the EKG leads, that are on the patient's chest so that it can see the patient's EKG and so that it can time the shock that falls right after the QRS complex somewhere on the R wave. So this is the sync mode. The button for it is usually here. If I press it, it will say sync. Okay, so now you know that your defibrillator is in the sync mode. Normally, what you would see is you would see a lead 2 displayed here, and you will see your nice QRS complexes, and the defibrillator will put little dashes on top of your QRS complexes on top of your R wave. Okay, unfortunately, our dummy is a dummy, so it doesn't have a heart rate or rhythm, so we can't see those right now, but you will know that your defibrillator is syncing when you hear little beeps and when you see little dashes on top of each QRS complex. That means that you are synced to the patient's cardiac rhythm and you are able to cardiovert. Now, cardioversion can be done at different energy levels. Atrial fibrillation is the hardest to cardiovert, so usually the energy level will go up all the way to 120 and sometimes 200 joules. But remember, those are synchronized, so it's not the same as defibrillation. For rhythms such as ventricular tachycardia, sometimes 50 to 100 joules is enough, and that will depend on your doctor's prescription. So once you are connected and synced and you see a nice QRS complex, usually in your lead 2 that is displayed, and you see little dashes above them, you will ask your doctor, what do you want me to charge the defibrillator to? And according to the ACLS guidelines, the doctor will choose one of the energy levels to start cardioversion. So there are different types of rhythms that can be cardioverted, but the idea of emergency cardioversion is really as an emergency intervention for a patient who is hemodynamically unstable. So if a patient presents with tachydysrhythmia, but their hemodynamic status is not compromised, cardioversion would not be the first intervention to go to. Pharmacological interventions would be more appropriate for these patients. If a patient presents with a tachydysrhythmia that is unstable, this is where we would go ahead and cardiovert. For example, in this patient, we see that this patient is very tachycardic. We cannot exactly see the source of the tachycardia because the heart rate is quite high, but it appears to be supraventricular. And the blood pressure is very low. As I mentioned before, this is a good example of a patient that might require cardioversion because they are clearly unstable. Types of rhythms that will normally be cardioverted are atrial flutter, atrial fibrillation, any sort of ventricular tachydysrhythmias that still have a pulse. So, for example, ventricular tachycardia with a pulse, paroxysmal ventricular tachycardias, and any kind of re-entry ventricular tachycardias. Re-entry ventricular tachycardia means that there are two foci or more in the heart that keep stimulating each other, so the heart keeps firing a lot more frequently than it normally should. So now if we proceed with cardioversion for this patient, and my colleague is actually taking care of the defibrillator, we're just going to look at the monitor and see what happens if this patient is cardioverted. So you will see the same jump, you will see a period of asystole after a rise in electricity. Unfortunately for this patient, the cardioversion didn't work, so the patient went back into their tachydysrhythmia. In this case, we will continue with CPR as needed and follow the ACLS guidelines.